So welcome everyone. It's early here. I'm coming from the United States, and I live in Boston, specifically in Cambridge, Massachusetts, where we are a major source of the COVID virus right now. So many of us are still under restriction or limited restriction. So we have some challenges. And what's been helpful for me is to use some of the sociocracy principles in some of the work I'm doing right now. So I'm a social worker, and I had been working in a range of settings, mental health, healthcare over the years, both here in the United States and parts of Europe. And I also live in a co-housing community where we have been using sociocracy now for almost 5 years. I was trained actually by some people involved with Sociocracy for All, Jerry Koch Gonzalez, and we have transferred from consensus decision making to sociocracy, which we have found very, very helpful. So in my work as a social worker, I have had very, very stressful, as people know, if you're in the field, you may work in a setting or be involved with a very hierarchical system, but yet lots of challenges, emotional, usually not enough money. And I had thought, well, why can't I integrate some of the benefits of sociocracy in a work setting? So I began to start doing this in different ways. And I'd like to share some of those experiences and get feedback because there are a lot of challenges, and we have had a lot of success. And I have found it to be one of the major positive parts of using this system in terms of helping not only our staff, but also our clients. And going forward, I'll use the word client instead of patient, just because there are lots of different terms that are used. It's maybe not very empowering, but it's just a little bit generic now across, some areas of, practice, whether it be medical care or human services or social services. The other thing that had happened, I've been doing some work now with COVID projects that we've had to ramp up very, very quickly. And it's been a very chaotic, stressful situation. So we have found that using elements of this have been very helpful. This is using sociocracy for decision-making in social services and medical care. And as I mentioned, it's a useful tool that I have found these settings. I had not been able to find much information on this. My experience has been, it's very, very new. I think it's been very, very challenging to utilize in these more hierarchical settings, which have very rigid roles. And often the client is really not given much power in the system. So I'm going to review just basically what we're going to cover today. In the short time we have. It's the basic sociocracy tools that I've been utilizing, the benefits that I've seen over the past couple of years I've been doing this, challenges, potential implementation steps, talk about 2 case examples, one from a psychiatric inpatient unit and one from a social worker providing family therapy in the home. And I'll talk a little bit about the COVID projects. I'll add that, and then questions and answers that might have. So the basic components used, most of you are familiar perhaps with the range of sociocracy in the process. My experience has been in co-housing that any of this overall structure needs to be or should be adjusted to the particular situation. So for example, in co-housing, we took the overall structure, components, parts, and we adapted it to our particular community and an American culture, governance agreement. So in the settings of human services, medical care delivery, that's the only way I felt that could function. They're incredibly administratively challenging systems. The roles are very rigid for any of you who have worked in there. So I have felt that you can only utilize basic components because you're adding a system of decision-making of values that isn't necessarily congruent with the larger structure. Many of us, in my setting, I work in a lot of medical institutions, which is very dominated by academic medicine, Harvard University, the universities, and the roles are very rigid. So the concern is to use parts of DG that would not be initially threatening or challenging, but would show the efficacy and hopefully be then made more credible. So the circle structure is clearly key to identify who should be members of certain groups, of certain circles, very clear about their aims and domains. And I have found this is very helpful for people in position of power, such as doctors, where they're afraid of either losing responsibility or in many cases, which is valid, they have a concern about risk level if they are giving decision-making to another staff person, particularly a non-professional. So having the linkage of the circles really helps. It shows that doctor, look, this circle might be directly linked to your area of responsibility. The other thing I found helpful is it really helps the other staff who are non-professionals, mental health workers, who often spend, for example, more time with the clients. If you're on an inpatient unit, you may see that a doctor or psychiatrist, some professionals spend very, very little time with the clients, but yet have the most power. Roles, the occupational roles are pretty clear. The roles in a circle, we've restricted them for practicality to really just a leader, facilitator, and note taker. There's really not much time to have delegates, or sometimes you might just have one or two circles. So it's important to distinguish between the professional roles, occupational roles, and the role of note taker or leader. And to not have the more professional person always be the leader or facilitator. A decision-making process has been the foundation that I have found so useful because you are really seeing how decisions are made, the consent process. Another key part is the evaluation. By letting people know you'll have a review for the decisions that being made. The whole mantra of good enough for now, safe enough to try has been very, very helpful in having people say, okay, let's give it a chance. It's not going to just go into limbo like some decisions are. This has a very, very rigorous way of saying, what have we been doing and when are we going to evaluate this? So when we've had some reluctant professionals to say, I'm not sure, they go, okay, I see another month or another even 2 weeks. I can see there's a process to see if it's not working. The other part has been a strong component is measuring outcomes. To obviously, as you know, in sociocracy, it's a loop. You use the information to get feedback for improvement. This has been very helpful to show that this process has been useful. It's been very beneficial for staff and the patient or client as well. And the key is flexibility. Again, we're going into a very, very rigid hierarchical structure, even if it's a social service agency, outpatient center. There's not going to be the philosophy to obviously embrace sociocracy in a certain type of way. And I have found that as long as we have the basic components, we have to make a lot of compromises. So it's not pure sociocracy in the best sense, just because there are so many limitations. Overall benefits, I want to talk about given a very, very specific structure that's been very helpful. And if you're a member of the circle, as you know, with equivalency of voice, everyone is recognized as being valuable. One of the reasons I had been interested in this, I had gone to a meeting a couple of years ago at a psychiatric inpatient unit, and there were about 8 people in the room. The doctor, psychiatrist ran the meeting. That client was there, which isn't so typical. Only 2 people spoke out of the 8 people, the psychiatrist and head nurse. And I knew from the work I was doing that that mental health worker had the most contribution to offer on the client status. No opportunity, didn't feel comfortable. He didn't feel comfortable speaking. He wasn't a professional. And this structure allows for that. There's a recognition. Why are you a member of the group? We've had you participate, you're a member, you're equal, with the recognition that obviously there are power dynamics. And we can't take away the reality that as an MD is an MD, and they're not going to give up certain power, but there is in that structure recognition that there's value for those people who are part of the group. Another key thing, if any of you are in human services or this work, you know that feelings can be very strong. There's a lot of traumatic, maybe experiences you've had, frustration, the concern about how working with clients affects you. We see a lot of suffering. We see a lot of, actually in some cases, serious risks, suicides, loss of children from many things. This structure allows for a feeling, a recognition of the feelings, and that's part of the process. Without any judgment, this is part of our given. With a decision-making process, you're forming a proposal, so the support of more rigorous inquiry of interventions and effectiveness. You actually show why you've made a decision to do a certain thing or use a certain medication or have the client try this type of therapy. You actually can see that in reasons why you did or did not maybe do something. Because there are so many members of the group, there's also the benefit of increasing the potential for more holistic understanding. Again, because you have more parts of the treatment system in that room with people empowered to speak from a range of things. Decision-making process, you may have gone into meetings, there's a lot of discussion, narrative, it's not clear what's happening. And often in human service and medical settings, there's often not an agenda. It's more, how's the client doing? What's up? It's very, very vague often. And you get documented in some notes, but the notes could be nothing to do with what was discussed, hard to read. So the meeting documentation is very organized and very clear. And I have a meeting template at the end, which I've used, which we have found very helpful. There's an increased sense of ownership. Because you have so many people involved, they're more likely to be more motivated to do the hard part of the work because they have input and they have a way of actually seeing if things worked. The other thing we've seen, it's been very beneficial for seeing how the clients can understand like why certain things were done or why can't you visit your mom this weekend. So it often is very, very clear, specific information. Challenges, I've limited this because I probably challenges of 5 different slides I could fill up, but the main ones are obviously, you could have significant limitations due to the government requirements in your state, in your country, and health insurance requirements. That is a given and you have to work around that. Some of the doctors are required to make decisions. We may not have a choice or the documentation need for health insurance. We found that many of the professionals lack trust in this process. They fear loss of authority. They fear concern about liability. The equivalency of voice. Always the client is part of the circle. However, is that realistic if they have significant impairments, if they're ill? How are they having their voice heard? What is their participation in the decision making? And can a client advocate Criticism from professional peers. This is not really professional. What's going on? A problem with risks. What happens if you let that mental health worker, take that client outside and they attempt suicide? Again, 2 sets of records may be needed. You might have the documentation for your decision making, but legally it can't go in a chart, it can't go in any records. And the major challenge, obviously, which is how do you find the time and money and a trainer to do this? Because it does take an investment. Implementation. One nurse who works with us on this says, I see this issue as a larger issue. We have a client and we only can take DG and inject a little bit like a needle into the system, and hopefully that will benefit the larger body. So we had looked in some of these agencies, institutions for support, or even benign neglect. What we have found is when you have a very, very challenging, difficult client population or problem, the administration might say, well, try anything you want. I don't know what to do with this. This is a real problem. So even benign neglect is helpful. Obviously, you need a skilled facilitator and trainer. And this is challenging because sometimes you don't have that in your system. Obviously, you have to bring someone from the outside, and that takes time and money. However, when we've recruited interested staff, we have found people are willing to work outside their regular jobs because they see this as such a possible benefit for themselves. They're burning out, they feel frustrated, they would like to do more with clients. Start slowly. What we did in a couple places is started too quickly. We changed the whole system. We had a process and it was too much with too many people, and it should have started in retrospect with 1 or 2 cases. Get a small group of people who are involved and just start slowly. As I mentioned, you can possibly try to get this as a pilot project. We often find there is more receptivity if we say we're going to try this process with some individuals who just have been either what they call treatment resistant, or there's been nothing that's been useful in terms of working with them. The other thing is key for implementation is if you establish clear standards, getting data, somehow having a way of documenting what the benefits have been. And we've done this from either the very hard data, which is reduction in use of hospitalization, perhaps less expulsion from school, less child neglect, to anecdotal feedback, narrative feedback. So it'd be important to show both for yourself, the staff who are participating, the positive benefits, also possibly to administration, and also for you for obviously improving the program. So I'd like to talk about 2 case examples right now to illustrate how these have been used. These systems are sociocracy approach, and we don't probably use the name sociocracy in this. People don't. So we give a name to our project depending on where we are in the system. So it could be a name that we've chosen. But here's an example of a psychiatric hospital unit. It's the same unit where I mentioned the client was there, the staff were there, but no one spoke except the doctor or the mental health worker. So we decided to try a different model. There is a circle formed. Key people were in it, the nurse, the mental health workers. There were 2 on each shift. The psychiatrist, medical doctor would come in as a member because the client had some medical problems. The discharge plan was the topic at that point. So people were very clear which circle they were in and which subcircles were needed. So for example, in this case, there is a treatment team circle, and a smaller subcircle was formed because this was going to be the transition plan. And they had their aim and domain addressed. It was very clear how much time they could decide about having the client go out. off the unit, who would accompany him or her, where they would go. So that subcircle made those decisions. They worked out the schedule, and the psychiatrist typically, as I mentioned, spends less time with the patient. And you had the mental health worker, who was the leader of the subcircle, decide on the times, decide who they were going to visit in the community. And they had really, really valuable information. They observed the client's social interaction, how they made decisions, what their cognition was like. Much more valuable than any other staff person in terms of planning the next step. And so that, because that subcircle was directly linked to the core circle, which involved the psychiatrist, she felt less concerned about, oh my goodness, the mental health worker is taking all these risks. What if he tries to run away? I won't know about it. I have to sign out. So that's an example of it having the circle linkage very, very helpful for decreasing some of the professional's anxiety if a non-professional worker had the main decision-making in the subcircle. So that allowed for the range of roles, particularly a person who was not a professional, to have a key decision-making in their subcircle. Another case example, in-home counseling, there is the social worker working with a family, and in this particular case, the social worker goes to the home because the children are not willing to come into a clinic, and there is funding to do in-home counseling in this. Conflict where they're actually telling the children to pick one or the other. There's a problem with visitation, a lot of anger, probably past history of spousal abuse, even though there's a denial of that. So the model that the social worker is using is the sociocratic model. The circle is the family. There are needing to be clarity that there are limits of what can be done. That's very important in a social service medical setting, as you know, to be clear about you as a worker, your legal obligations. In this case, they had to be told that the social worker did have some possible obligation that had to go beyond the circle. That social worker was the facilitator and the leader. That just had a role that, because that's a major responsibility, it's a lot of work, and it wasn't sharing equal roles in a certain type of way. So that social worker was the facilitator, the leader, and the note taker. The other clear advantage is all were members of the circle, and it was very clear all could be equally heard, not necessarily easily in some settings. And as all of you know, there are both hidden and unclear power dynamics in a family. And this allowed for at least the opportunity and expectation that everyone would be heard. The other thing that was very helpful was the decision-making process. As people know in this field, a lot of decisions or discussions or a lot of feelings, emotions come out. In this particular case, it was anger. It was retribution, the parents wanting the children to pick one or the other. There was a lot of history of arguments, no positive way of settling conflict. And we found this structure really helped grounded people. And it really helped regulate emotions because you could come back to the process. And it was very helpful to have separate subcircles. This was clear that the subcircles maybe were separate for parents and children, and those were to discuss certain things that might be only relevant to the children or to the parents, or they have some discussions about the divorce that the professional would make that isn't appropriate for children. Each family member gets a copy of the meeting notes, so it's very helpful for a couple of families we've worked with where their English is their second language. These were very concrete measures they could look at. They kept them, they looked at them till the next meeting. It was very, very useful. The main positive thing about this is it provided a structure that was very grounding, allowed for a lot of flexibility. It's a little bit more outside the model because the social worker has a more prominent role. And this is not technically part of the equivalency of voice, but given a high conflict family, given the emotions, it's not realistic to train people. It's a use of a model with systems of working, not necessarily people being equal in the same way, but family members obviously can have a role and they can be heard equally, but there is a power dynamic there, and the problem with having to only come in once a week and you're concentrating on the family's problems and hopefully resolution. The other thing that it offered to this family was a very, very helpful way of how to solve conflict. And eventually the social worker was able to help train them in using this model. Here's an example of a meeting template, which we have found very helpful and suggested. Obviously can be much more structured and very useful for documenting in a more medical setting, but also we've used this as a guide for the families, for example. So the meeting, what the meeting is, who's there, who isn't there. It's very, very important. Sometimes meetings you don't realize that some people are absent, they didn't have any input, their voice was not heard. The date and time. The time, we usually do an agenda for a very, very busy medical unit, has maybe 50 meetings a day. They want to know what's the agenda is, when it ends. That's very helpful to actually allow a certain amount of time for certain items. In the family situation, no, it's too bureaucratic. What's key is the check-in. Obviously, people are familiar, you go around and check in. You see on the right side where notes are recorded, there is no place to record those check-ins. So people know that how they feel, what they say is not recorded in their check-in. Very important. It's confidential in a sense, it's not part of the notes. It not only recognizes that you should check in about how you feel, it recognizes your emotional needs, but also recognizes you don't have to feel self-conscious. Any announcement that's housekeeping, even the kid might say, you know, I'm going to play soccer and like, you know, half an hour, I'm really, need to go or whatever. The discussion, the specific that agenda item is we were reviewing this particular client's treatment goals. He was the one who's leaving the inpatient unit. In the right column are only decisions and follow-up. It's very, very clear who's doing what, very easy to see, to go back to. Joanna knows what she has to do for the next meeting. The 955 is an example of a very specific proposal that was going to be made. And the decision-making process was used. You know why the medication was changed, the pros and cons, what else was perhaps being considered, why didn't it work. Here's the decision documented. It will date for when it will be reviewed. So the client was reluctant to have this medication. He could see, wow, I don't have to wait for 5 months, April 20th. And who's going to follow up? Next topic might be just a general discussion, the discussion for housing resources. No decision, no follow-up, might just be a brainstorming, what's available, how expensive is it. Checkout feedback can be very brief, can be doing in rounds, and that's obviously for each person. We have a checkout very brief. And then the end of the meeting, some people really, really want to know how much time they have to spend. I need to get out and go to work, on another unit. So modifying this has been very helpful for different settings. And this, as I mentioned, we give this to the family members. They clearly see why things were done, why decisions were made. They refer to this. I, as a social worker, can use this. I can have this in a client's record. Here's why we did or didn't do something back in January, and here was the outcome.